We're delighted now to be joined by two of our experts on assisted suicide who have spoken so far today. They are Professor Patricia and Dr. Pauline Kane. So we wanted to talk a little bit about your talks and go more in depth on what you've shared so far today with us. Patricia Casey, in particular, you talked about the contagion effect that assisted suicide legislation can have. So is that, in your estimation, backed up by clear data? And is it something people should be aware of, that this might lead to an increase in overall suicides?
It certainly is something that is backed up by data. I mentioned in my talk, and I'll mention it again, the Jones and Patton study published in an American journal that found that when they looked at the suicide rates in Oregon and Washington in 2015, that there was an increase of 6.3% in the suicide rate overall, and particularly in those over 65. And then the work of Theo Boer, the Dutch ethicist who at one point supported assisted suicide but no longer does, and when he looked at the suicide data from Holland, found that there was a 30% increase over a 15-year period. So it is backed up by solid data, and it's of great concern because we've put an awful lot of time and effort and money in this country into reducing our suicide rate, and it has been reducing. And my concern is that if there are now going to be two categories of suicide, a good type, the assisted suicide, and a bad type, which is suicide, it's going to give incredibly mixed and confusing messages to the public.
So it seems to be a total contradiction, but also normalizes the idea of suicide in people's lives?
It's very much normalizing the idea of suicide in people's lives if they believe that in some circumstances suicide is a good thing. And that's of course what assisted suicide would be saying, and what the proponents say, that these are personal autonomous decisions that people should make for themselves, and the bill death with dignity. I mean, who could be against death with dignity? So that's the contradiction I think that people will be faced with, and that will normalize it because dignity is a good thing. And so if you allow suicide with dignity, it will be perceived as being a positive thing, when in fact it's something that every doctor should want to avoid, because we shouldn't be doing harm to people, and we should be putting in place structures and assistance so that doesn't happen.
And Dr. Kane, you're an expert in this field, you're a consultant in palliative care, and you've obviously been there with so many people who have went through the passage of death. A lot of the time, I think, in people's imagination, when they consider assisted suicide, it's for people who are really in unbearable pain. So is that realistic, that people are dying in unbearable pain at the moment?
You're so right. It's so often people will say to me, both people that I meet as patients and their families, that they have this fear of someone dying, screaming in agony, and this intractable pain. And I think years ago there were deaths like that. I can remember as a child my father coming home very distressed, having met a work colleague who had lung cancer, and saying that the man was roaring in pain. And I often think of that, how now we are so fortunate with modern medicine that that is no longer the case. I have an armoury of drugs which I can use in various combinations, and it will always be our first reassurance to anyone we meet: we can manage your pain, we can manage any symptom, shortness of breath, anxiety, anything that you're concerned about, anything you would experience, we will walk through that with that person and use the drugs that we have. So no one dies in intractable pain. It just does not happen because we have access to the drugs in the modern medicine climate that we're in. We're very fortunate, so that is never going to be the case, and myself and my colleagues would strongly feel that never happens once you have access to good palliative care. I think that's the key here. You need to have access to good palliative care. If you don't, yes, there is the potential of you dying in intractable pain. And I had a relative 20 years ago who had a non-cancer diagnosis, and he died, to my mind, with pain that he should never have had. But at that stage he could not access palliative care because he didn't have cancer. Half of the people I see now have cancer. The other half have conditions like heart failure, diabetes, multiple sclerosis, MND, that sort of thing. And it's recognised now that the symptom burden for those people is the same, if sometimes not more, than cancer. And so once you can access good palliative care, you are not going to be in tractable pain.
And I think a lot of your colleagues have came out and expressed their reservations about the assisted suicide legislation that's been proposed. I think, is it fair to say there's a large majority that are against it?
There is a large majority who are against this, and I suppose we have concerns. You know, palliative care is still a relatively young speciality in this country, and we really don't feel it's, even among our fellow colleagues, it can be poorly understood as to the services because we are new and we're developing. And really watching the discussions in the Dáil, it's very clear that the politicians there do not understand what the role of palliative care is and what we can give to people who are ill, who have terminal conditions. We offer holistic support, physical symptoms like for shortness of breath, for pain, psychological distress, social issues and spiritual distress, although that piece is supported in palliative care. And we give people the opportunity to discuss their fears, their anxieties. Like often when I meet somebody, they've been through the medical system, they're worn down, they're terrified. A terminal diagnosis is a very scary thing. It's a very lonely place to be. You might have lost your job, the money isn't coming in, maybe you were the carer, now you're being cared for, your role has changed, there's a lot going on there, and you can feel like why continue, what is the point? And in palliative care, our aim is to really reassure that person that they're still alive and to get their quality of life back on track so they can continue to live using the drugs and our multidisciplinary team, or physiotherapy, or social work, or OT that's available to us.
And is there a possibility that there could emerge a burden to die almost, that old people would feel that, or those with terminal illness would feel that they don't want to load any more responsibility on their family for the vulnerable situation that they're in, and they may feel a burden to accept assisted suicide? I
think that's a real fear that we have, and you know, often when I would meet someone, they'd say, I really feel like I'm a burden to my family. You know, before I was the carer, I was the financial provider, now I'm the person that have to mind me. Some conditions, particularly conditions such as MND, it's recognised that the person has a lot of care needs, so they need a lot of support. So really the emphasis should be on saying, well, how can we give that person support? How can, as a public, as a government, how can we put the money there that they can feel supported to be at home? The answer is not assisted suicide. The answer is looking how better can these people be supported and how can they access good palliative care so their concerns, be they physical, psychological, social, can be addressed. Talking to colleagues internationally where assisted suicide is available, when someone opts for assisted suicide, any opportunities to discuss their fears around dying and death and so forth, it's no longer an option. And to my mind, to die afraid, to die with physical, psychological distress, to die feeling you're a burden to your family, is not to die with dignity. To die with dignity is to have the opportunity to talk to somebody, to allay your fears, to have the chances to have those precious discussions with your family members, your friends. We always mean to do, we never have, because it's such a precious time when you know you have a terminal diagnosis. Although on one hand it can be truly horrific, it gives you that time to have those conversations with your family. And with palliative care support, the physical piece can be supported, any distressing symptoms that you have can be alleviated and managed. So you don't have to worry about dying at the end of life. Our business is providing and ensuring that people have comfortable and peaceful deaths, and that's dying with dignity, not assisted suicide.
So it's quite clear we don't need assisted suicide in order to alleviate people's pain, and there are obviously care methods there. But I wanted to ask you, Professor Casey, about your experience of dealing with people who experience suicidal ideation. You've done that, I think, throughout your career, and tell us something a little bit about what you might say to politicians who are proposing this as a solution simultaneously for people who feel the despair of a terminal illness.
Well, the first thing is that many people with suicidal ideation do so because they're in crisis. They've got a terminal diagnosis, maybe they're unemployed, they have a broken relationship, but they're in crisis. And for the most part, to those people, you can say that things will get better. But for those who won't, like those who have a serious life-threatening illness, you can assure them, and I can confidently assure them, that the array of treatments that are available from services like the palliative care team, if that's what they need, will assist them with that. So they don't need to think about suicide. The reason, in fact, that many people think about suicide, particularly older people, is because they feel a burden. And if they're fading, they're getting frailer. They may not have a terminal illness, but they feel that they're getting in the way of their family in some respect, and they feel they'd be better off gone from this world. That's one scenario. So the kind of existential depression, as we'll call it. The other situation is where people actually have an underlying depressive illness that hasn't been picked up, it hasn't been diagnosed, because they don't go to their doctors to talk about it, because they don't want to talk about it. Sometimes they don't actually have a language to talk about it. And that group are very worrying, because depressive illness is a treatable illness. And so if somebody is terminally ill, has that stressor in the background, they can easily become depressed, but not want to talk about it because they don't want to further burden their family members. And they may well think about suicide, and they may well request assistance in dying in those circumstances, when in fact they've got a background condition like a depressive illness that's actually manageable, so you can take away that element of the distress from them. When you treat people with depressive illness, it's actually very rewarding, because all of their doubts and their fears and their terror about the future and their desire to leave this world will all fade, and they will be really glad that they're alive. We notice that when people make serious suicide attempts on their lives, like people who come in after they've taken serious overdoses or tried in other ways to end their lives and had a plan, and we actually treat them, they're so grateful afterwards. So I would say to people and to politicians that because somebody asks for suicide, it doesn't mean that they either necessarily need it, because they may well respond to treatment, or B, they may not even in their heart of hearts want it, but feel that they have no other option to get them out of their current misery.
And in a sense, listening to Professor Casey there, I think it'll be clear to all of us that it seems as if the medical profession is crossing a Rubicon if it takes the step of starting to take people's lives instead of helping them and enjoying the rewards as well of helping them. Is this a monumental shift for the medical profession if it's to go down this route?
Yeah, and I think we have a dual concern. One is that it will irrevocably change the relationship between the doctor and the patient, where there's one of trust at the moment. I would walk along with someone during their illness, and I would explain about the different medications I use, because in palliative care we're very conscious that nothing we do hastens a person's death, and we would always give that reassurance. Sometimes people have concerns around morphine and other drugs that they're shortening the person's life, and we would very reassure them that is not what we do. You know, we're here to relieve your symptoms and to get your quality of life as good as possible. So really that piece. And then the other piece as well is, you know, palliative care is dreadfully underfunded in this country, and is really not appreciated for the role that it provides. Everyone dies, we all die, and yet there is a distinct lack of full, what we would call multidisciplinary teams in palliative care. We should have access to nurses, physiotherapists, social workers, speech therapists, dietitians. There are many teams, and they have hardly any of those services. And really the emphasis needs to be on the funding of good palliative care. If the shift moves towards assisted suicide, that's lost. The momentum behind that is lost, because good palliative care is expensive, like healthcare, but the rewards are great, and there are studies out there showing that it's good value for money. We support people making complicated choices about what medical treatments are suitable for them and not, and that opportunity is just going to be missed.
Well,
Can I say from my personal point of view, I had occasion to have contact with palliative care physicians in relation to somebody, a family member who was terminally ill, and I was absolutely assured by the palliative care people that they would guarantee that the person would not be in pain, and they would do whatever was needed in terms of giving pain relief to that person to ensure that there was nothing like screaming in pain or anything like that, and that turned out to be the case. So from my personal point of view and my personal involvement with palliative care physicians, I can say I can vouch for everything that Pauline has said, and for that being the ethos of palliative care.
What about people with motor neuron disease? Are they helped with palliative care as well, or is their pain beyond help in some ways?
Well, I suppose the issue with if you like, non-cancer conditions like motor neuron disease, heart failure, emphysema, that pain can be an issue, but they can have other distressing symptoms as well. So the pain, we have the drugs for that. Pain is not an issue in palliative care. It is not an issue. That's our bread and butter, if you like. And we can always manage the person's pain. If someone has shortness of breath, sometimes in motor neuron disease and end-stage Parkinson's, for example, people worry about choking, about their swallow being impaired, slower. People with emphysema worrying about feeling they're going to suffocate. And those sort of things. They may have had a relative, I've seen that before, but some of these conditions run in families. So they've seen a relative have a horrible death, and they're terrified that that's what is in store for them. And I suppose it's to give people the reassurance that we have a gamut of medications. I have so many different drugs that I can pull on and put together, and I have non-drug approaches as well that we can use so that those symptoms are addressed, those fears are allayed, that is not going to happen, that someone is not going to die of suffocation or choking. You know, there are lots we can do in modern medicine to ensure that people are kept comfortable, and as things change over the course of the day, we check in, we make sure, and we adjust accordingly to ensure that person is comfortable and passes away and dies in a comfortable state.
Well, I think that message will be very reassuring for everyone listening and for everyone concerned about this legislation. So, Dr. Pauline Kane and Professor Patricia Casey, thanks very much for being with us here.
Thank you.